The earlier we start, the better. Everyone has risk factors and they can change their life, but everyone has them. And so understanding your risk is imperative to preventing disease. Everybody should be incorporating healthy lifestyle from birth. And so we want to take what you learn on this podcast and teach your, 2 and 3-year-olds, right? Whether they're kids or grandkids, and start early. So that's it. That's something I'd like for people to recognize is we need a little bit of a cultural change, and we can prevent a lot of our chronic disease if we start early.
Welcome to Season 3 of Eat Your Greens with Dr. Black, the podcast where we make health doable through the power of evidence-based nutrition and lifestyle habits. I'm Dr. Black, and I cannot tell you how excited I am about the upcoming season of the Eat Your Greens podcast. This season, we're taking everything we learned in Seasons 1 and 2 about nutrition and lifestyle and turning it into actionable advice that you can start using today to start improving your health. And we're jumping right in with this first episode of the season. Did you know that cardiovascular disease is the #1 killer in the United States and has been for a long time? If you or someone you love is affected by high cholesterol or high blood pressure, heart disease, or even stroke, and let's face it, that includes most of us, right? We all know someone. Maybe it's someone dear to you, like your parents or your grandparents, or maybe it's you who's been told that your cholesterol is too high, or maybe you've had a heart attack. If this describes you, you are really going to want to listen to this entire episode. I'm honored to be joined today by Dr. Kelly Ratheal. Dr. Ratheal is originally from Dallas, Texas. She received her Doctor of Medicine from Texas Tech School of Medicine in Lubbock, where she also completed her residency and her fellowship training. Dr. Ratheal is board certified in internal medicine and cardiology, and she's also a diplomate of the American Board of Clinical Lipidology. And that means that she has extra training in managing cholesterol and the other lipids that cause heart disease and stroke, things like that. She currently practices at Christus Health in New Braunfels, Texas, where she brings a strong focus on prevention through evidence-based lifestyle habits. Dr. Ratheal is here to teach you how you can get your cholesterol down and prevent heart attacks and stroke. She's going to talk about when and why medication is useful, but also what you can do either instead of or in addition to medication to keep your heart and your blood vessels healthy and working at full capacity. And if you're not yet affected by high cholesterol, or maybe you're a parent trying to keep your family healthy, she's going to tell you why you have the power to prevent cardiovascular disease before it starts. So please help me welcome Dr. Kelly Ratheal to the show. Thank you for joining me today, Dr. Ratheal. It's really a pleasure and an honor to have you here. I was very happy to meet you not too long ago and discover that we have lifestyle-focused cardiology in the community here in Central Texas. Why don't you get started by just telling me a little bit more about your career and how you came to integrate lifestyle habits, lifestyle focus into your traditional cardiology practice.
Hi, Dr. Black. Thanks for having me. I'm flattered that you asked for me to give some information on your podcast. It takes a little searching to find other docs in the community that are focused on prevention. So I appreciate the opportunity. My practice is a general cardiology practice that's focused on bread and butter cardiology, but there's always a little bit of lifestyle and prevention input. I would say all my patients get a bit of that. And then I have a growing group of patients who come solely to understand their risk and to take preventive measures to reduce that risk or optimize it. My patients range from 18 or 20 years old to 98 is my top right now. So there's always something that we can optimize from a lifestyle standpoint or prevention standpoint. The earlier we start, the better. Everyone has risk factors and they can change their life, but everyone has them. And so understanding your risk is imperative to preventing disease. And so that's the gist of my practice. We have worked over the past several years to build a system that helps educate patients and support them in their lifestyle changes. And so we have an exercise physiologist on staff and a dietitian and a team of clinicians that help patients by providing frequent visits that are very education heavy and help patients build a program to change their habits for the better so that they can reduce and optimize their risk. Oftentimes that means, I would say, certainly in the younger patient population, reducing medication burden in exchange for healthier habits. And in the aging population, I think the thing I see most often is that they regain some of their independence, confidence, ability to perform even activities of daily living, take a bath, those kind of things, more safely and without being so worried about hurting themselves. And that's a nice thing to be able to help somebody have.
I love hearing that not only can people reduce, as you said, their medication burden, so especially younger people, but just that idea that even once you have some cardiovascular disease or if you're older, it's not too late. It's never too late. You can make some changes, and often they're not huge sweeping changes. They can be pretty manageable. And even still regain some of that confidence, function, maybe vitality.
Yeah.
That's the message that we're trying to share, right?
So I don't see kiddos, but I think that you obviously have a audience that's very kid focused. And, if whether it's older children or parents that are listening, risk assessment doesn't have to, nor should it begin after 18. And so I think we'll talk about a few key points certainly from a lipid or cholesterol standpoint that are important for screening and risk stratification of children. But everybody should be incorporating healthy lifestyle from birth. And so we want to take what you learn on this podcast and teach your, 2 and 3-year-olds, right? Whether they're kids or grandkids, and start early. So that's something I'd like for people to recognize is we need a little bit of a cultural change, and we can prevent a lot of our chronic disease if we start early.
Well, that leads me to a question that I've had. When should I, as a pediatrician or families, start thinking about cardiovascular disease? I mean, how young does it start?
So we know that atherosclerosis, or the deposition of plaque in our arteries, starts before age 10. And we have evidence now that it may start even when we're in the womb. It's a ubiquitous disease process. And I think what most people, and myself included, don't grasp is that this happens to everyone. You were asking about screening for cholesterol for kids, and this is an important topic. The universal screening recommendations, meaning for every child, are that they should have a cholesterol panel between the ages of 9 and 11 and 17 and beyond. In patients who have a family history of high cholesterol, so their parents have significantly elevated LDL, I would say over 160, or siblings with that, then they should be screened earlier. If the family is known to have familial hypercholesterolemia, which is known as FH, those kiddos should be screened at 2 years old.
As early as 2?
At 2.
How would somebody know if they have familial hypercholesterolemia, FH? What are some of the clues that we should look for that might indicate that?
Typically what you'll see is that they have early cardiovascular disease. So often, if they just have one bad gene, then they may have heart attacks in their 40s, or strokes, or need a stent. But they have clinical cardiovascular disease by their 30s or 40s. If they have 2 bad genes, then they often have cardiovascular disease by the age of 20, and may have had bypass or heart attack at that age. And so those families have early cardiovascular disease, and it's in every generation. There are other lipid abnormalities that can create pictures like that too, but that family history should certainly be a trigger to check the kid and to maybe have the adult have a conversation with somebody like me. So Yeah, that's
And that
message.
highlights, we learned that in medical school, right? The
Mhm.
importance of the family history.
Yeah,
And it just shows it's true. Like
yeah.
you knowing what runs in the family, and that helps to prompt us for early screening. Tell me, what about the role of some of the other tests? So you mentioned the cholesterol panel and triglycerides. I'm starting to see more talk about measuring things like apolipoprotein B and something called LP little a.
Right.
When should pediatricians be thinking about measuring that, and what does it mean? Basically, should I be adding that to my lipid panels?
Sure. Um, so we don't have, I would say even expert consensus in the pediatric world. We need to be measuring ApoB, lipoprotein little
Right.
a, or LP little a. I think probably has a more immediate role for you to incorporate. Um, After the age of 5 is what I understand at this point. We think that that number is set. So lipoprotein little a is an inherited risk factor, meaning our diet, exercise, lifestyle choices don't impact it much at all. And so if it's high, you got this high version from mom or dad, it's high your whole life and it increases risk tremendously. It's very potent. And so everyone should be screened once in their life for lipoprotein little a. And we think after the age of 5. So to give you a little frame of reference, LP little a is high in 1 in 5 people. And it's really nasty.
And if you know that you're one of those people, and that's 20% of the population, what extra steps should you do? How should you approach that?
You should be a lot more aggressive about treating what we can treat in terms of risk because we can't take away that risk factor. So using medication to meet more aggressive goals earlier in life is the mainstay of treatment right now.
Well, that's a nice segue into treatment. When it comes to your adult population, I know a lot of patients are on the statin medications. I've had parents and other adults in my life who have very strong opinions one way or the other about that. Can you talk a little bit more about the sort of conventional or pharmacologic treatment of high cholesterol? And then we'll move into what else it might be available.
So most adults live with an LDL somewhere around 100 or above for the majority of their life. And this tends to create visible, if not clinical, atherosclerosis or cardiovascular disease by our 70s or 80s. This is a dose-dependent problem. So the longer we're exposed to cholesterol, the more we make plaque. The higher that cholesterol is, the sooner we make. So remember, I talked about those FH patients who have an LDL of 400 or 500 from birth. It only takes them 20 years. If LDL is 200 or 300, it takes them 40 years. If LDL is 100, it takes them 80 years. You see this area under the curve concept. I always tell my patients that if we're having a conversation about treating your lipids, it's because we've come to a point where we're not meeting our risk reduction goals with lifestyle alone. And some people have really mildly elevated LDL and they can optimize it enough with lifestyle that, we're not in a risk category that warrants medication use, or maybe not at an age at which we'd like to introduce medication to reduce risk. So remember that medications are an excellent tool to help us age well, including statins are the mainstay of therapy still, although we have many other categories of drugs. But they help stave off clinical cardiovascular disease, meaning heart attacks, strokes, death from those things, if we start them earlier. So waiting until disease is present is too slow. We're 30 years behind. We can still save lives that way, but it doesn't prevent the disease. We can prevent the clinical manifestation of cardiovascular disease. Most of the time, it requires medication. It's a good tool. So statins specifically, you're right, people have strong opinions, and I find that generally it's on the negative side. They've gotten a bad reputation. They're safe and well tolerated if they are dosed appropriately. So I think a lot of why they've gotten this bad reputation is patients wait too long to treat their risk. They come in with an event and they get put on the highest dose because that's how our studies were designed and those are the doses guidelines recommend. and then they have side effects. And that's how those drugs work. We get the best LDL reduction or, lipid lowering out of the first dose. Sometimes we get a good increase in the reduction with the second dose, but beyond that, we have really minimal or diminishing returns and many more side effects. So the lower doses you're getting the most bang for your buck there. And then as we increase, we add side effects. And that's actually backwards from the way the guidelines are written because of the way studies were designed. And that's beyond this conversation. I don't keep patients on medications that give them side effects. They're not going to take it. It's not, I wouldn't want to do that to myself. Like what? So if we have a side effect, we adjust the dose, we change the med, we find a different regimen. And luckily, those muscle side effects that come with statins sometimes are reversible. And so when you stop it, it goes away. And really, we're talking about myalgia or muscle aches the majority of the time when we talk about statin side effects. The other part of the statin concern, I guess, is people always ask me if it's going to give them dementia, if it's going to make it so they can't make testosterone. This is not an excuse, okay? So I don't know how much you want to get into the biology of those questions, but the answer is those are not clinically relevant concerns and the mechanism is just not there.
It's good to know because I'm sure a lot of people see that on social media or wherever, there's a lot of misinformation out there, but it's reassuring to hear that.
Yeah, they're safe and they're very effective and they're still our first line tool. So maybe be open if your doctor says they're worried enough to use. If you think you have a kiddo with FH, then we should be treating them and we should do their genetic testing. So I can certainly help you.
I have, of course, a large number of adolescents in my group where when we do their fasting labs, they're coming back with, maybe not super high cholesterol, but moderately high triglycerides often. What's the difference between LDL cholesterol or other forms of cholesterol and triglycerides? And why should I be concerned? Or why should my patients be concerned when I tell them, like, hey, your triglycerides are high?
Here's the lifestyle part of lipids. Okay, so people think, Dan, I can't make my LDL perfect with diet. No, but we can make your triglycerides and your HDL normal. So both of those numbers are reflective of our metabolic health, meaning how is the engine running? Do we have enough muscle? Are we insulin resistant or pre-diabetic or diabetic? Are we working really hard to process the fuel that we're giving our body? So triglycerides and HDL are two of the 5 numbers that, when they're abnormal, constitute metabolic syndrome. The other 3 of those numbers are waist circumference, blood pressure, and blood sugar. If 3 of those are abnormal, that defines metabolic syndrome. So this is something you see in your patients, I'm sure already, which is sad. And that's very lifestyle dependent. I see it in the majority of my adult patients, and we can fix that. So by changing our lifestyle habits, our sleep, our exercise, our food, those are the big 3 levers I teach my patients about changing, but things like stress and air pollution and noise and all of those things contribute to our health. But those 3 are your big levers for metabolic health. And so when triglycerides are elevated, it indicates that the liver has more fuel in the form of fat than it can distribute efficiently. And so another little lipid fun fact is LDL. People think its purpose is to deliver cholesterol, but that's not what it does. What's being delivered is triglycerides. And so when they are too numerous, that number rises above 100. And we also see HDL, or good cholesterol, fall in concordance with that. So HDL goes down and triglycerides go up. And this is pathognomonic for insulin resistance and poor metabolic health. We can fix those things with lifestyle changes. And so this is the part of cholesterol that we can change with lifestyle significantly. And that our first line treatment for is not medication, it's lifestyle. So improving your sleep to where it's adequate in terms of hours per night and it's restful is important. Building as much muscle mass as you can is one of the best things you can do in life. Do it early, sustain it, keep your muscle mass. Go ahead and try and look like Arnold Schwarzenegger, okay? You won't do it. It's not going to happen. Don't worry about it. Try. Okay. This will help maintain metabolic health better than almost anything else you can name. So build your muscle mass and keep it up. The fuel that you put in does matter, especially if we already have some energy imbalance or insulin resistance. We need to put better fuel in, meaning less processed food. We want to eat whole foods, as Dr. Black is so good at describing on her podcast. And having a very plant-forward or even wholly plant-based diet can help quite a bit. Incorporating enough fiber and lowering our saturated fat intake, in addition to lowering those processed foods that we talked about, can help improve insulin resistance. So just make those swaps. I'm going to get rid of my cheeseburger and I'm going to have black beans and avocado and maybe tofu, if you like tofu, or edamame or any other plant-based protein sources. So exchanging animal protein sources for plant sources can maintain your protein intake, but also inherently increase your fiber intake and decrease your saturated fat intake. And we find that this is beneficial metabolically.
And you've mentioned saturated fat a few times. Tell my listeners a little more about why saturated fat is important. Where does it come from? What are our main sources? And what role does it have in our cholesterol or our triglyceride levels?
So I'm going to stick first with the triglycerides because we've been on that train of thought. Almost every patient you encounter with high triglycerides will be in this realm of metabolic dysfunction. So their triglycerides are somewhere between 100 and 500. Anyone beyond that is a little bit different conversation, but the majority of what you see will be in that realm. And they're very responsive to carbohydrate intake, meaning those refined carbs. Now, I'm not talking about broccoli or spinach, guys. Okay. So bread, pasta, rice, chips, tortillas, sugar-sweetened beverages, alcohol, baked goods, candy, all of those things are refined carbohydrates. When we reduce that intake, we reduce triglycerides fast and tremendously. Okay, so that's usually the number one dietary advice. But saturated fat intake does play some role in insulin resistance. And we've explained that usually those elevated triglycerides in that range with a low HDL indicates insulin resistance. There are several reasons why reducing saturated fat seems to improve our cardiovascular risk. And this is reproducible across many studies. But if we exchange saturated fat for poly or mono unsaturated fat, we'll tend to see that risk reduces. Saturated fat also seems to, and in some patients disproportionately so, increase their LDL. And so if you find that you're more responsive to that than other things in the diet, then it might be something worth avoiding, especially if you have a focus on LDL lowering. It can, even if you're on medication, help reduce the dose that you might require. And so those are part of if we're going to move the needle on LDL with diet, reducing saturated fat and increasing fiber are the two mechanisms that improve. I think fiber is your workhorse, though. I mean, in my experience, a lot of patients are, we're just not eating much fiber, and there's no upper limit to fiber. You can only get so low with saturated fat, nothing, but the floor is not that far away, and there's no ceiling to fiber. And so that's a nice avenue for reducing LDL with diet, is really increasing fiber. But you got to do it slowly. My dietitian always reminds me to tell our patients that you got to do it a little bit at a time over several months, because your gut bacteria have to adjust, and we got to get used to processing those plant foods. But it's a very healthy choice. So our fiber intake correlates with our mortality inversely. So the more fiber we eat, the less we die, or the later.
And my listeners know I talk about it on every single episode.
There you go.
And so I'm so happy to hear you say that. So you heard it. It's not just my opinion. The cardiologist is saying
helps your LDL, triglycerides, helps your inflammation, helps your blood sugar.
So many things.
That's great. So when patients come to me purely for prevention, they come to our cardiometabolic clinic and they say, hey, I heard that you can help me lose weight, make my blood pressure better, control my risk, maybe get off some meds. What do I need to do? I say this requires blood, sweat, and tears. This is how we are going to be successful. I take your blood. You don't have to bleed otherwise. Sweat, because if you don't sweat, we will not be successful. I expect you to exercise and I expect you to push yourself. That's how we get stronger. We talked about building muscle. And tears because it's hard. And people aren't always successful in the way that they expect to be. Maybe the trajectory is different than they expect. And so I have been trying to find the best way to convey what the program looks like and what the expectations are from our side and what they should be from the patient side. And that it's important to know if this is a good time in life to take on this challenge because blood, sweat, and tears.
Yeah, I love that analogy, blood, sweat, and tears. And I think it's important for doctors. I mean, we are people too, and we know how hard it is. But sometimes when we're giving advice, it's easy for us, to say, oh, just move more and eat less. Like,
Right.
oh, okay, doc, sure, I'll get right on that, And it's important to recognize how hard it can be, and especially the blaming and the shaming that a lot of people get either from family members, friends, society in general, or often, unfortunately, from their doctor. And so I'm glad that you put that tears part in there because it lends it a lot of legitimacy of, okay, yes, it's hard. It's also why one of the main reasons I'm trying to shift my practice to this metabolic health clinic, and I'm exploring culinary medicine and also through the podcast. How can I move from just telling patients in my office, do this, just get your kid to eat more broccoli. Like, what's the big deal? To, all right, let's find actionable things. Like, how can we make this doable? How can I make health doable in ways that's very accessible, even to the point of like, let's come in together and have a cooking class. And what can we do to really give our patients the power to make those changes so that maybe there's fewer tears? It's still going to be hard. We live in the society we live in, but maybe we can just make it just a little easier, a little fewer tears, and work through it together.
Yeah. I think the more community we get involved, the more fun it is, So, I guess our equivalent of the cooking classes you're talking about are our group lectures that we do in the community. So I tell my patients, I'm like, bring your kids, your grandkids, there's snacks, it's free, it's once a month, come and learn something, and maybe there's something to walk away with that you can implement or help you understand your own risk and lifestyle changes you might make. Because, if we can get the community's attention as far as just teaching kids when they're little, if we start doing that, then a generation or two from now, things will look different. If we're really all picking up this need to have a different approach to our lifestyle. But it takes time. I don't know if we see it in our lifetime. But
all we can do is be a part of the message, be a part of the culture shift, and slowly we'll get there. I have to have hope. Do you have a patient success story? Somebody who was able to make some changes?
That's a good question. The answer is yes, but I feel like it's more an amalgam of patients. Just to give a general example, let's say somebody in their 40s comes to me, male or female. They usually have relatively young kids, and they've had a decade of kind of letting themselves go, and now primary care is telling them their cholesterol's high and their blood pressure's high and they're too fat. And then, we need to focus on you a little bit, right? And they seem, oftentimes they're kind of statins that this has happened, but not surprised because it's very culturally normal. But when they show up in my clinic for that reason and they're willing to see me, they're usually motivated. They came to that visit, and if we get through the lots of information on the first visit about insulin resistance and sleep, muscle, exercise, diet, and they think, okay, make me a plan. And they follow that plan like it's medicine. Within 3 months, they say labs change. Maybe their blood pressure's coming down. Within 6 months, sometimes we're taking them off something or getting rid of medication. And these are fairly young patients, right, in the big scheme of things, which is why at the beginning I prefaced that it's more likely if we're in the first half of life and already on medications to reverse that requirement I think in the second half of life, we've accumulated enough risk, unfortunately, that we're not going to eliminate medications entirely. Our risk will not reduce to that. And that's just something that needs to be understood. If you want to optimize risk and you're over 50 or 60 years old, then there's going to be a medication involved. And it's to optimize your risk. You can choose to do without it, but it means your risk is higher. But in those younger patients, I can see often they just have this confidence as they're moving through this that they recognize, oh, I can do this. Like, I'm not 50 years past the last time I was able to run up a flight of stairs, or be as fit as I've ever been. They have this, like, I don't know, maybe veil cloud lifted about thinking they're determined to be as unhealthy as the rest of the American population, and they're not, because they made a big change. But it's a very big change. These patients usually read all of the material I've given them, which is multiple books. They wear the continuous glucose monitor. They go to every visit I set out for them, the exercise physiologist and the dietitian, and they do everything they're instructed to do. And they're very successful. Blood, sweat, and tears. Though there's a spectrum. So the people who adopt some of it, we can see some improvements, certainly. But those kind of miracle stories are because those people put a lot of effort in. And they trusted this.
So it's not without hope. You don't have to be perfect.
No.
If you put in some effort,
right,
you'll see some benefit.
Yeah.
If you put in a lot of effort, you'll see a lot of benefit. And if you put in all the effort, you're going to see huge benefit.
And the success story, I would say on the older patient side, is reduction in angina or chest pain. So when they start exercising and eating right and getting good sleep, and their clinical disease manifestation, it dampens, and their quality of life is much better. There are different successes.
And that's a big deal when you're really suffering and having those symptoms and can't walk, up your stairs in your house, to being able to be a little bit more active, have better quality of life. I think often then it can have a little bit of a snowball effect. Once you have a little improvement and see, oh, I can breathe.
Yes.
Then it helps motivate
Breathing
us.
is important.
Truly. I do think it's one of the challenges that I face as a pediatrician, because my patients are not symptomatic, right? They don't feel their increased triglyceride level.
Right.
And why should I make any changes? It's I'm active and young, and it doesn't matter.
Most of my 30 and 40-year-olds aren't yet. Some of them have some disease with symptoms, but when they show up for that reason, that's how you know that they're at least entertaining the idea of making some changes legitimately. I don't know. It's hard to treat risk.
I encourage my adolescent patients to talk to their grandparents or extended family, about how they're feeling and what they're going through, especially if they have heart disease or diabetes. Tell me, if you could change one thing about how our healthcare system approaches cardiovascular disease prevention and treatment, what would it be?
The prevention side is the harder side. So understanding that we're all going to make plaque and it's going to show up on a scan at some point in your life, if you're lucky enough to live that long, or if you have enough risk that it happens earlier, is important. Because there's a point in time where medications are going to be appropriate for almost everyone to optimize risk. And people say, well, I don't want to take medicine because I'm healthy. And why should I have to do that? And it's viewed as this sort of failure, right? Like, now I'm unhealthy and I need to take a medication. And so I think from the prevention side, understanding that it's a tool to maintain quality of life and stave off chronic disease that is likely to interfere with your life at some point, and the most likely thing to kill you, you're choosing to invest a couple decades ahead to push that off so that, when you're 80, you can travel and see your family and walk by yourself and do whatever, or 90, whatever. We don't want this 10, 15-year marginal decade, it's been called, where you can't really function very well and you're miserable and you're in pain and you need another stent and you got chest pain. No, we can prevent that to a large extent, but it has to start early, and it means treating risk and often with medication when you have no symptoms and no visible. From the
Makes
treatment
sense.
side, meaning we already have disease, see your cardiologist regularly. Like, if I say I want to see you in 6 months, don't show back up in a year and a half. You know, uh, make an effort to have regular visits so that we can work on risk factors and even incorporate things like lifestyle modification to improve how you feel and maybe reduce your med burden, how many medications you're taking or the dose. And not just preventing heart attacks and strokes, but if you already have disease, find somebody who will treat it aggressively because guidelines are not aggressive. They are the minimum standard. So find somebody who's going to teach you and educate you. And
What do you think the future looks like in terms of where cardiology is going, especially with the growing interest in lifestyle medicine and food as medicine that we're seeing sort of nationally?
I think that you'll see a growing percentage of general cardiologists who have a focus on prevention because we can prevent a lot of the chronic diseases we've discussed, a large percentage of them, but it takes its own subspecialty to identify and treat patients early. And so I think you'll see that that becomes a more recognized specialty because we understand this connection to many chronic diseases that stem from metabolic dysfunction early in life. And so I think you're going to see that it's, as you get on that train early and you're in your 20s or 30s and you think, should go talk to somebody, about my investment in my health, right? So go talk to somebody about your investments and your finances. Go talk to somebody about your investment in your risk reduction. And there'll be people that where their practice is geared to advise you in that way.
I like that analogy. You're investing in your future. So that's great. So I just let me take a moment to do a little recap and sum up some of the major points that we've talked about. Cardiovascular disease can start as early as in the womb in some people. We're starting to see that evidence. And definitely by the age of 10, you can see some measurable changes already in the blood vessels. But that doesn't mean that it's hopeless. There's still things that we can do. But being aware of your family history is very important. How early did people in your family start having heart disease? If they're starting in their 40s or earlier, we really need to be more aggressive, especially as pediatricians, in screening our patients earlier than what the standard guidelines indicate. Medication is the first line therapy for a reason, especially for things like your cholesterol, your LDL or bad cholesterol level. And if it's done thoughtfully at appropriate doses, it's quite safe and the side effect profile is very tolerable for most people. So don't be afraid. And if your doctor is recommending it, pay attention and maybe consider, don't feel like you're a failure because you're already starting medication at a younger age.
Absolutely.
Having said that, there is a role for diet and lifestyle, especially with your triglyceride level. That's the thing. And even though triglyceride is a type of fat, it is intimately related to diabetes. We think of diabetes as sugar and heart disease as fat, but actually they're closely related, and that's because of your triglyceride level. And an elevated triglyceride level is a marker of insulin resistance, so diabetes or impending diabetes. And that's where we have the most power to make an effect through our lifestyle changes. And that's going to be predominantly by getting that refined processed carbohydrate intake down, getting the saturated fat down, and increasing fiber. And there's no upper limit of fiber intake. There's no ceiling, but go slow because we all know side effects of too much fiber too fast. We've all experienced it. The other main lifestyle habits that you should focus on for preventing cardiovascular disease and cardiometabolic disease are sleep, so important. And I am going to do a sleep episode in season 3. And also exercise. In fact, building muscle may be the number one thing that you can do to protect your metabolic health. When we go through the process of lifestyle change, there will be some blood. That's the labs that we measure, some sweat. In fact, should be a lot of sweat with the exercise. There will be tears as well, but it's worth it in the long run. and look to doctors like you and me who are, our mission is to help you make those changes with the minimal amount of tears. But it's okay. I mean, if it's hard, it's okay. It means okay. You're putting in the effort. Don't be afraid of it being hard. It's going to be fine.
That's how we grow.
Yeah. And you indicated that for many people, if they're really putting in that effort, they can see significant changes in their lab markers within as little as 3 to 6 months. And I think that's very powerful. We're not talking about results 30 years from now. We're talking about results in the short run that can really extend not only your lifespan, but also that health span, the number of years of your life that you're actually healthy and can have high quality of life, be active, and enjoy your life. And we want our health span to be as close to our lifespan as possible.
That's right.
So how did I do with the summary?
Excellent summary.
I appreciate you joining me and taking time out of, I'm sure, your very busy schedule today. Where can people find you?
I am at the Christus Trinity Clinic in New Braunfels. You can Google me and find where I work. You are welcome to call and ask for an appointment if you want one, if you are over 18. And Dr. Black can help you if you have kiddos that you think need other expertise. So my partner and I do have a website that we've created for patients. It's called NB, like New Braunfels, NB Prevention Docs, DOCS.com. And it just has a compilation of resources that we have found helpful for ourselves and our own education and also for patients. There are a book list, a podcast list of episodes about topics we discussed today and also many beyond this talk so that you can learn in more detail. And there are going to be recipes and exercises from our dietitian and exercise physiologist. There are healthy eating resources that are local and tips about reminders about healthy living. There's going to be info about common lab tests, commonly asked questions, and supplement use. So there's a pretty broad spectrum on there, but probably something for everybody.
Sounds like a great website. I will be sure to put the link in the show notes and maybe add it to my website so people can go. And for anybody who is interested in hearing a little bit more about the lab tests that we discussed, LDL, triglycerides, things like that, I did do an episode a few months back. I think it was specifically called Understanding Your Lab Tests. And so I invite listeners to go back and listen to that one if they want to hear a little bit of a fun, lighthearted approach to how those numbers come about and what role what we eat may have in how we can affect change in those numbers. So thank you again. I appreciate your time, and I look forward to talking more with you and exploring how we can work together to improve the health of people here in Central Texas of any age.
Absolutely. I'm looking forward to it. Thanks, Dr. Black.
Thank you.
Please be aware that this podcast provides general health information about nutrition and feeding of infants and children and is meant for educational purposes only. It's not intended to replace the important relationship between a parent, child, and pediatrician. If you have concerns about your child's nutrition, health, or growth, please consult your doctor.